Welcome, everyone. Thank you for joining us today. My name is Allison Drew. I am the program coordinator for the Iowa Regional Autism Assistance Program. Welcome to the Autism Basics Webinar Series featuring Dr. Jillian Reiher. This session is on what is autism. I would like to give a friendly reminder that certificates of attendance and foster parent training credit are available for the live sessions only. And now I am happy to introduce Dr. Reiher. Jillian Reiher fell in love with working with children with disabilities, both on the ice, teaching ice skating, and providing in-home behavior support after college. She earned her PhD in school psychology from Illinois State University and completed her pre-doctoral internship and postdoctoral fellowship at the Monroe Meyer Institute in Nebraska. During her postdoctoral fellowship, Jillian participated in the LEND training program. She has been a staff psychologist at the Center for Disabilities and Development since July of 2020. In that role, Jillian sees children for evaluations and therapy. She is on two of the Center for Disabilities and Development's autism diagnostic teams and has been trained in Project Impact. Jillian also spends a day per week in the Biobehavior Services Day Treatment Program. And Dr. Reiher also serves as a psychology technical consultant for Iowa's Regional Autism Assistance Program. And outside of work, Jillian is the proud owner of an adorable and sassy bunny. As we go through this session, questions can be typed in the Q&A box, and Dr. Reiher will respond to them at the end of the session as time allows. And now I will turn it over to you, Dr. Reiher.
All right. Thank you, Allison, and thank you all for joining us today. As Allison said, we're going to start off today with just talking about what is autism. As Allison said, there'll be time for questions at the end of today's material, but you can also email me. So my background is a little bit different than the WRAP Family Navigators. WRAP Family Navigators are parents of children with autism or other developmental differences, and I'm approaching this as a psychologist. I know that there are a lot of different opinions in the autism community about using identity first language, as in autistic, versus person first language, as in a person with autism. I will use them interchangeably throughout this series. And then I did also want to note that while a lot of the information will be applicable wherever you're tuning in from, some of it does have an Iowa focus. As a little bit more information about the Regional Autism Assistance Program, it is part of Child Health Specialty Clinics, which are part of the University of Iowa Division of Child and Community Health or the Department of Pediatrics. And it helps Iowa families navigate local supports and services for autistic teens, children, and young adults, so birth to 21. WRAP teams can help families connect children or connect to autism information, communicate with diagnostic providers and healthcare providers, explore insurance coverage and payment options for ABA and other needs, and help navigate the education system. As a professional, one of the things I really value is that they can also talk to you as a parent, as somebody who has lived experience raising a child with autism. I have been fortunate to work in this field for a few years now and get a good amount of information on autism and work with lots of autistic folks. But I still don't know what it's like to raise a child with autism. And so it's nice to have somebody who has that background. So the Family Navigators are part of the WRAP team. They, as I said, are also the parent of a child with special healthcare needs, and they can help listen to your concerns, offer emotional support, and connect you with local supports and services based on your family's needs and goals. And that can be as foundational as education, but it can also be things like, hey, there's a autism-friendly event going on at the local library. Here's some information about that. There is no cost for family navigation services, and the only criteria is to be a family in Iowa. So to be connected with a family navigator, you can contact Erica Hartel, and her information is posted here. So today we're going to look at autism from a few different angles. We're going to talk about what it is generally. People have lots of ideas and perceptions of what it is. And so we're going to get down to the nuts and bolts of what actually is involved in an autism diagnosis. We're going to talk about how we diagnose autism, talk a little bit about causes of autism, and then talk some about research on early signs and symptoms of autism. So when I think of autism, oh man, I think of so many different families, wonderful people that I've had the chance to work with. Also, a variety of systems that autistic children and their families are involved with. Um, Autism can look so many different ways. Some of you may have seen or heard of the show Love on the Spectrum, which involves autistic adults trying to date and find love. And The Good Doctor, Sheldon Cooper are examples in kind of pop culture. Dr. Temple Grandin is a noted animal scientist and autistic self-advocate. So even within just looking at pop culture, we can see that autism can look a lot of different ways, and this is still just a tiny representation of the spectrum. So, at its absolute core, what autism is a developmental disorder characterized to varying degrees by difficulties in the areas of social interaction, verbal and nonverbal communication, and restricted and repetitive behaviors. And you can see here, those all kind of go together. Social and communication are interlinked, as are the communication and the restricted and repetitive behaviors. The criteria for diagnosing autism comes from the most recent edition of the Diagnostic and Statistical Manual of Mental Disorders, or DSM. And this is the kind of standard what we use across the country to make a diagnosis. So current criteria, as of the most recent update, I believe was in 2024, is persistent deficits in social communication and social interaction across contexts. And we need something, at least something, in all of the three areas of social emotional reciprocity. So that might be not noticing others' emotions or noticing them, but not responding to them in a way that feels good to the people who they're interacting with. They may not respond to those back and forth information or interactions. Um, we also need to see some difficulties with nonverbal communication behaviors. So that might include eye contact, that's kind of classic, but it also could include things like using or understanding gestures or other people's nonverbal cues, or understanding that, like, oh, if somebody is standing there with their arms crossed, that means that they are not happy. Or, we could see a total lack of facial expressions or nonverbal communication. And then we also need to see some difficulties with developing, maintaining, and understanding relationships. So might have difficulty adjusting behavior to suit certain context, or with imaginative play, making friends. Some folks aren't or don't appear to be interested in interacting with peers at all. And then we also need at least two in the different categories of restricted and repetitive behaviors, interests, or activities. So it could be stereotyped or repetitive motor movements, use of objects, or speech. So we think of kids who echo or who say the same words and phrases over and over again out of context. Hand flapping would also fall into that category. We might also see insistence on sameness or really strict adherence to routines, patterns of behavior. So we get really frustrated if mom goes a different way home from the grocery store, or get frustrated with our friends if they change the rules of the game because that's not the rule. We might also see really strong interests that are above what we would expect for a child their age. So we might see a kid get really, really fixated on all they care about is zoos of the world. I think is one of my favorite ones I've seen. And that, kind of most things relate back to zoos in one way or another, and they can tell you a lot of great information about that. And outside of that, we might not see as much interest. And then we can also see folks be under or oversensitive to sensory input or aspects of the environment. So maybe not seeming to notice pain or temperature differences, getting upset by different sounds or textures, or conversely, really loving certain sounds or textures. The symptoms have to be present in the early developmental period. So if we have somebody who was typically developing until they were 10 years old, and then all of a sudden we're starting to see some of those things on the last couple of slides, we definitely want to look into it, but it's probably not autism. But we might not see the full level of impairment or difficulty until social demands exceed capacities. So sometimes for kids who have thinking skills similar to their peers, they may not show enough difference for us to say for sure, yes, this is autism until they're a little bit older. Or on the other hand, they may show more of those symptoms early on, and then as they get older, they might not as consistently show those difficulties or those differences because they've learned certain things like, oh, they are going to insist that I make eye contact, so I'm going to make eye contact. Um, Symptoms also have to cause clinically significant impairment in social, occupational, or other important areas of functioning. And the difficulties have to be not better accounted for by intellectual disability or global developmental delay. And that's a little tricky because um, kids can and often do have both autism and global developmental delay or intellectual disability, but we just need to make sure that the behaviors we're seeing aren't entirely due to those conditions. We also have some specifiers that we can add, so with or without an accompanying intellectual disability or language impairment. If we know that it's associated with a known medical or genetic condition could include something like Fragile X syndrome or an environmental factor, or if it's associated with another neurodevelopmental, mental, or behavior problem. And then we also look at the levels of support. So before about 2013 or so, we had different types of autism. There were separate diagnoses under the autism umbrella. And if you've heard of things like Asperger's or pervasive developmental disorder not otherwise specified, that's where those came from. As of about 2013, those diagnoses went away and they are collapsed under the sole diagnosis of autism. And what we do instead is we talk about levels of support. So level 1 is requiring some support. This is for folks who, without supports in place, we see some of those difficulties in one or more contexts. For these folks, a lot of times when we get supports in place, the difficulties associated with autism kind of disappear. We might still see that they don't make constant eye contact or a flexible eye contact or that they flap their hands. Those are not things I would label as difficulties, but they're able to tolerate small changes in their environment when we set up the supports or have meaningful relationships with peers once they have support. Level 2 is requiring substantial support. Um, this is where we're seeing more of those difficulties with verbal and nonverbal communication. Even with supports, we're still seeing some difficulties. We're also, for restricted and repetitive behavior, we are seeing it frequently enough that somebody who doesn't know this person, who maybe just kind of sees them in a store, would notice it. And also that we are seeing more of that distress with the restricted interest in repetitive behaviors. And then level 3, requiring very substantial support, is severe difficulties with verbal and nonverbal communication, very limited initiation of social interactions, and minimal response to others' social attempts to engage, and then pretty inflexible behavior, real difficulty with coping with change or when restricted interests can't or repetitive behaviors can't happen. And it's really affecting all functioning. So a couple notes on levels. One is that especially if your child is younger when they're diagnosed, and if they give a level is a best guess. It's the first time we've met your child in a lot of cases, and we are going based on your report, what we're seeing. Um, but essentially, it's us just trying to summarize and capture what's the information that we've gathered so far. So I know that sometimes people get really, they really want to know the level. And that is absolutely your right to know, but I don't know that it's always as helpful as people think it is. Because, saying level two doesn't tell us like, well, actually, your kid does a great job with initiating social interactions, but they have a harder time responding to other people's social interactions. And so that's the part we need to work on. And, they have some rigidity around lining up toys, but otherwise changes in routine aren't a problem for them at all. And that's the stuff that's more important when we're talking about an individual child's strengths and weaknesses. And then profound or severe autism is um, a term that is starting to gain some traction. It is not in the DSM at this point, but it is a way of attempting to, I said we kind of collapsed all of the autism diagnoses into one, and this is a way of trying to separate out some folks who really do need more support than many other people who meet criteria for an autism diagnosis. So this is somebody who meets all criteria for the DSM, um, but also have cognitive and functional impairments, need pretty much constant lifelong supports and services and supervision. Many of these folks are nonverbal or have limited use of a language system, have intellectual impairment. Many have challenging behaviors like aggression, self-injury that interfere with safety and well-being. This is not particularly what we see in pop culture a lot of the times. A lot of the times, like I said, we see those folks who are dating or working as scientists, and we don't see as much of those folks who need the more substantial support. I will say also, I've seen some like new proposed criteria for this, and one of them that I really love is that while we would still diagnose autism at the ages that we currently do, we would not diagnose profound or severe autism until around age 8. And kind of like with my talk about levels, I do think that's a fair thing to do because it is really hard to know how a 2 or a 3-year-old is going to grow. And I know that I would not feel very comfortable giving profound or severe autism to a toddler. And the folks with severe or profound autism, depending on the study, make up about 20 to 50% of autistic individuals. So, as we've talked about a little bit, autism is one diagnosis that can look so many different ways. We can see folks with severe intellectual disabilities or people who are cognitively gifted, and sometimes within the same child. So, we might see a child who has severe language impairments, but their visual spatial skills are way better than mine. We might also see children who are not particularly interested in social interaction, or kids who really are, but maybe don't know exactly how to initiate those interactions. We have kids who are verbal and kids who are not yet verbal. We have different levels of sensitivity to sensory input. Some of them struggle with coordination and some do not. Some quick facts. As of 2022, and so the report came out in 2024, but based on 2022 prevalence data, there is 1 in 31 children have autism. It was 1 in 150 in the year 2000. The percent identified varies by location, and there's currently about 3.4 autistic boys for every one girl with autism. We have closed a gap in identifying um, Black children with autism compared to white children with autism, but we still are have lower rates of identifying Hispanic or Latino children with autism. I had the opportunity to attend a great conference last week where we had a presentation on prevalence. And I don't know about you guys, but I've been hearing a lot about that 1 in 31 number, and I had lots of questions. And luckily, one of the presenters was somebody who participates in that data collection. And so, one thing that I thought was important is that it's gathered from 16 sites across the country. So, when we say 1 in 31, we're not actually saying 1 in 31 for the country. We are saying 1 in 31 from those 16 places, which are not 16 states, by the way. It's like parts of counties sometimes. Also, the number and types of states have varied based on the different monitoring sessions. So I know one of the things she showed us is there was a pretty steep jump when California joined. And so there's some changes based on who is being screened. The diagnoses are based on record review. So they look for a medical diagnosis like we would provide here at the CDD, an educational verification, or and I did not know this, and apparently this is a somewhat more recent um, add-in, that about 9% of the cases reported are just an ICD-10 code. So that's just somebody in their chart saying F84 autism. Um, that was personally a little concerning to me because, I know from working with electronic medical records that sometimes you click on the wrong thing and we catch it and we fix it as soon as possible. But if it's anywhere in their chart, um, I think that leaves it open to concern that some of those may not be accurate cases. On the other hand, in 2018, they also cut out expert review of charts, which allowed psychologists and expert clinicians to go through the case files and also see if there were children who were essentially they were describing all of the diagnostic criteria of autism, but maybe still didn't have that medical or educational verification. And then another thing that I thought was super interesting is that the largest increase in prevalence that we're seeing is in children with average language and IQ. So, I know when I see that 1 in 31 number, it makes me think like, oh my gosh, what has happened, especially when we see the growth. And what that information would indicate is that maybe we're just really getting better at identifying some of those cases where before we maybe would have just thought those kids were quirky or a little socially awkward or things like that. Another question I get sometimes, especially if I'm talking to older family members, is how long has autism been around? I hear we didn't have this when I was a kid, or, I never knew anyone with autism. And it is hard to say because we can't fully apply diagnostic criteria to the past when those things didn't exist yet, but we have some historical examples of folks who sound like they would probably be diagnosed with autism if they were alive today. Um, One of them is Victor of Aveyron, who was born around 1788, and he was a nonverbal child who eloped frequently. He was described as um, he was thought to be a feral child, that he had not been raised by anybody. But the more you look at his behavioral profile, the more it looks like somebody who had pretty high support need autism. And then there was also a Scottish gentleman at the earlier 1700s, Hugh Blair, who was described as um, socially awkward and kind of gullible and, cognitively could do a lot of what his other peers could do, but socially was not what was expected at the time. But as far as autism as a concept, in 1908, the word autism was used to describe a subset of schizophrenic patients. In 1943, there was an American child psychiatrist who described a subset of children who were very intelligent, but described a powerful desire for aloneness and an obsessive insistence on persistent sameness. In 1944, a German scientist described a form of autism, and he at that time reported all boys who were highly intelligent but had trouble with social interactions and had specific obsessive interests. And infantile autism was listed as a separate condition from schizophrenia for the first time in 1980. And then in 1996, prevalence data started being collected on autism. So autism diagnosis is a tricky one because it's a clinical diagnosis. I always tell people there's no one behavior that can rule in autism. I can't say, oh, your child flaps their hands and therefore they have autism, but there's also no one behavior that rules it out. So I can't say, oh, that child makes good eye contact. They definitely don't have autism. So we look for patterns of behavior and those signs and symptoms. We do our evaluation procedures, and then, if appropriate, give an autism diagnosis. Generally, we're going to start with a diagnostic interview. So we interview parents or any other grown-ups who are available and interested about the child's social communication, as well as their interests and behaviors. We, especially when kids are older, when they come in, we look at their current behaviors as well as what they did when they were younger. And like I said, if we can get information from other children who, or excuse me, other adults who know the child well, we love that. And then we do some sort of systematic observation. Gold standard is what's called the ADOS, or the Autism Diagnostic Observation Schedule, which I always tell families sounds fancy, but really means in most cases we're going to play and see how the child interacts in situations. And those activities are designed to pull out those behaviors related to autism and then scored according to specific guidelines. The ADOS activities vary by the child's age and language abilities. So if we're looking at the toddler module, some things in the social category that might make us think, yeah, this might be autism, are not really smiling at others, not really trying to get others to look at things or draw their attention to things, limited eye contact, limited shared enjoyment, not a lot of giving or showing toys. In terms of communication, we may not see many attempts to communicate, and that includes things like gestures. So a lot of times I get people asking, how do we know this isn't just a speech delay? And when I see kids who just have speech delays, they are doing everything in their power to communicate with us because their words aren't working for them. So I see gestures, I see facial expressions, I see whatever they can do. We might also see some unusual intonation or repeating words. As far as behaviors and interests, we might see some like getting focused on some sensory things that we wouldn't typically observe. We might see some repetitive mannerisms or non-functional repetitive play or just general limited interest in imitating what other people are doing. And that is pretty atypical because toddler modules for children ages 12 to 30 months. And especially once we get to that like 18 to 24 months, you usually can't get those kids to stop imitating you even if you want to. We also try to get some estimate of developmental functioning. As I mentioned earlier, we have to make sure that what we're seeing isn't best explained by global developmental delay or intellectual disability. And what I mean by that is that if a child's overall cognitive skills are more similar to those of a 3-year-old and they're 5, then I expect 3-year-old good social skills for 3-year-olds, not for a 5-year-old. But if their cognitive skills are right on target and I'm seeing those social delays, or I'm seeing, their um, cognitive skills are similar. They're 5, their cognitive skills are similar to a 3-year-old, and their social skills are similar to a 1-year-old, then I start to have more evidence for an autism diagnosis. Causes is something we're hearing a lot about these days. But what we know is not as much as we wish we did, but we know that there is not just one cause of autism. There might be multiple causes for the same person. There are certainly multiple causes across people, and the outcomes can look very similar. About 15% of the time, there is a specific genetic abnormality that explains why an individual has autism, like Fragile X. One of the ways that we can get more information about that is there is a nationwide research initiative, and University of Iowa is one of the sites studying it. That their goal is to improve the lives of people with autism by identifying causes and informing more effective therapies, treatments, services, and supports. There's a good online community. They have a bunch of research that they've generated. Um, Although University of Iowa is a collection site, I think pretty much anybody can go on the Spark website and say, hey, my child has autism or I'm autistic, and get a kit sent to them and get that information collected. With Spark, unlike genetic testing that might happen through your doctor, if they don't find any genetic differences, they will never contact you. But they do rerun the information every once in a while. And they, if they find information in the future, um, they will reach out to you and say, hey, we've identified this gene. And here are all of the sites that are collections areas for Spark. So you can see pretty good across the country. So again, those causes of autism, genetics is really one of the main ones, but it's not explaining all of it. I know one of the developmental pediatricians here talks about how when he first started out, everyone really thought genetics was going to be the entire answer. And now they're finding out that it's a lot of times it's genetics plus early environment factors. So things like advanced parental age at time of conception, particularly fathers being older at time of conception, um, mothers being sick during pregnancy, particularly like if inflammation is involved, extreme prematurity. And sometimes when people talk about the increase in autism, we forget that medical science has also improved to the point where a lot of babies survive who may not have survived 20 to 30 years ago, and some of them may have developmental differences. And then certain difficulties during birth, like oxygen deprivation. There are other potential causes being studied, like immune system functioning, exposures to high level of pesticide, air pollutants, um, prenatal folic acid, pretty much everything is still being looked at. Um, and some of that research is being done through the IRDDC here, which is the kind of research arm of our Developmental Disabilities Service. And I had the opportunity to attend a talk through there where they were looking at mice models, so not humans yet, but mice, where they looked at the effects of um, air pollution and maternal stress on pregnant mice. And what was striking to me is what they found was both maternal stress and air pollution were required to see social differences in only male mice. And then my main takeaway from that is if it's that complicated for mice, which are raised and live their lives in a controlled lab environment, I can only imagine how much more complicated it is for humans. So there are some things that we know conclusively do not cause autism. Bad parenting is definitely one of them. The initial thought of what causes autism was called like the refrigerator mother, or a mother who is not cold, who is cold or unresponsive to their child. That is absolute nonsense. The MMR vaccine does not cause autism. There is a preponderance of data leading to that, and studies that have shown it, including the original one that kind of got everybody's attention in the first place, are low quality and in some cases have been retracted by the journals that initially published them. And then Tylenol is a newer one. And so there was, within the last couple of years, there was some research that seemed to show some association between Tylenol use and during pregnancy and autism. And there have been more recent studies with larger sample sizes and the controlled for more factors that found that no, that doesn't exist. Previous studies that found that relationship were not taking into account things like the mothers had prenatal illnesses that required them to take Tylenol, the maternal inflammation that I mentioned earlier, or um, that those children may have already had siblings with autism. So that, like I said, that newer study is a really great one that kind of goes through and controls for some of those things. And I want to talk just a little bit about some of the research on early signs and symptoms. So sometimes I still hear like, oh, we can't diagnose until they're older, or I just want to wait and see how things are going. But there are a good chunk of toddlers with clear-cut symptoms at 18 months that can have diagnoses that last throughout their lifetime, particularly if we're seeing things like limited eye contact, limited gestures, and limited giving and showing, or okay eye contact, but a lot of repetitive behavior and still limited giving and showing. We also see differences in attending to social stimuli. So there's a screening tool that has a task that is holding up two pictures, one of a train and one of a face, and seeing which one the child orients to first. And that doesn't diagnose anything, but it does give us some idea because most young children do have that preference for faces. We might also see less of what they would call sticky attention. So being able to um, focus on some of those social aspects, even really early on. Uh, we also see infant siblings having more risk for developmental problems, along with like a broader autism phenotype, meaning we're maybe not meeting full criteria, but we're definitely seeing some of those characteristics similar to older sibling. But on the good news, infant siblings are responsive to early intervention. So we might see some of those concerning behaviors and work on it, and things get better. And we do see prevalence rates for siblings being higher than they are for the general population, so about 10 to 20%. With autism, we also think about what's called developmental cascading. So that means that if we have a child who has a difficulty with an early skill, it might be just a little bit different from their peers at first. But if we don't address it, then all of those early skills build to higher level skills. And so then we see that gap grow bigger and bigger with time. So, for example, I am fully on team. You do not need to make great eye contact, but I am also on the team of joint attention is important, or being able to look at what other people are looking at. Because if you're not looking at what other people are looking at, then you're missing a lot of information and a lot of opportunities for learning. So as a baby, that may not feel like a big deal, but as a toddler, as that child is supposed to be learning more language and following directions, those sorts of things, then it gets harder. And if we don't get it, then it gets even harder as they get older. It is important to know the typical social communication trajectory so that we can diagnose children earlier. 'Cause what we know is earlier diagnosis leads to earlier intervention, which leads to better outcomes. Regression is probably my least favorite part of autism. It is incredibly common, particularly in terms of social communication. It's often observed over time, between 6 and 36 months. Notably, it does not correspond well to what people remember. So that is why a lot of times people will say, oh, this regression happened after a shot or after an illness. It's because those times stick out in your brain. But what I think is nice is we have a lot more video recording technology at this point, and so you can go back and look and you can say, oh, actually, we started to see some of those differences a little bit earlier than we thought. Um, and some research indicates that it might even start earlier than what we can easily detect through behavioral observation. Some just more information about autism. Autism Navigator has an awesome series that talks about what autism is, how it compares to how autistic children might compare to children who are typically developing, and some good information on interventions. So with that, I would love to hear any questions.
Feel free to put your questions in the Q&A box if you have any. We do have a couple in there now. The first one is, what do you use for a possible diagnosis if a child has many signs of autism but isn't quite checking all the boxes?
Mhm. So in terms of what I might use for a diagnostic criteria, um, or for like what diagnosis I might give, I might give something like a global developmental delay, especially if we're seeing delays in other areas. I might just note social skills difficulties or something like that. If they're young, like 3 and under, then I'm probably going to say we want to keep a close eye on this kid and see them in 6 months to a year to make sure that those gaps aren't getting bigger. If they're older than that and we're looking at autism, especially if we're in the 5, 6 range and we're looking at autism, but it doesn't seem to quite fit, then I really want to be looking at, is there something else that makes this make sense? Like I said, autism is a tricky diagnosis because it is a clinical observation-based diagnosis, but we can also look at like, okay, does ADHD make sense? Or does ADHD and anxiety in combination make sense? Or um, and none of those rule out autism, right? Which is another reason that autism is fun and tricky, but it does sometimes that explains enough of the difference. I also tend to focus on what what does the child need, regardless of what diagnosis or label I'm going to be giving them? There are some interventions, especially when we get to insurance, that are only available to children with autism diagnoses, which is very annoying to me. Um, but a lot of times it's like, well, I'm not 100% sure that this child meets criteria for autism. But what I want them to get is some extra training or instruction on how to handle their emotions or we need some practice on flexibility. And those are the same things that I'd be recommending, even if they ended up with an autism diagnosis. Let me know if that doesn't answer the question.
What diagnostic criteria would you use to tell if a child has autism or a cognitive intellectual disability?
Mhm. Yeah, and so the autism criteria are always the autism criteria. But when we're looking at, and that's why a lot of times, though this is probably less common if your child is younger when they're diagnosed, a lot of times we like to do IQ testing right with the autism diagnosis. And we also will look at their adaptive behavior or your report of how they do with activities of daily living. And so, like I said, I would look to see if there is enough of a difference between the thinking skills and the social communication or the restricted and repetitive behaviors. So, as an example, there was a kid I tested several years ago who was, I think, 8 or 9, and they were a little quirky. There were some things that were um, felt a little bit different socially than I would expect for other 8-year-olds. And then I did IQ testing, and the child's full scale IQ is a 48, where average would be between about 80 and 20. And that puts them like below, well below the first percentile for their IQ. And so with that information, that kind of reframed their social to actually kind of a nice area of strength for them. Whereas had that same child had a completely typical IQ, then I might have said, oh, those scores are not, those skills are not what I would expect from a child who has thinking skills just like other kids their age.
What is the best way to help an adult get an autism diagnosis?
Yeah, it's hard. It I believe the Autism Society of Iowa maintains a list of providers that you can email them and ask them for, and they note on there what providers do take autism evaluation or do autism evaluations for adults. Um, I will say it's tough because there are fewer of them, and they generally do not accept Medicaid if you do. But that would be my best advice for that one.
How do you differentiate between an autism diagnosis and a social communication disorder?
Yeah. So social communication disorder is the social community. So for autism, you have to have both the social communication and the restricted interest and repetitive behaviors. Um, for social communication disorder, you just have the social communication um, component. So it's kind of like autism minus the restricted interest and repetitive behaviors. I was trained to look very, very carefully because a lot of times if we have a social communication disorder, there is also some of that in that restricted interest and repetitive behavior category, even if it's a little bit lower. But there are some kids who, nope, that really doesn't exist for them. It is just the difficulties with social interaction, difficulties with nonverbal communication, sorts of things.
What should a family do if they still haven't heard back if our son is officially diagnosed? We turned the packet in, but haven't heard anything and haven't gotten an answer when we call.
Okay. Um, so if you have um if you have already met with a provider, I would contact that provider directly and ask them, whether it's email, if they work for like the CDD, like I do, and you've tried reaching out to the provider, then I would reach out to their supervisor or anybody else that you can at the institution. If you're waiting to hear on like if you filled out, like I know for us, we have folks fill out an intake packet before they're even scheduled. And sometimes there's a gap there because unfortunately we have nowhere near enough providers for how many kids need autism evaluations. I think you can unfortunately probably just still keep trying to call um, the place where you are trying to get evaluated and seeing if they can give you any more information about like, hey, do we need anything else to schedule your child um or those sorts of things. But yeah, definitely if they've already had the evaluation, reach out to the provider. If the provider doesn't get back to you, reach out to their boss.
What is Iowa doing to provide more services for kids with autism, like OT speech, PT, social time, meetups, etc.? Waiting lists are so long for specialists, and we need more awareness on how to find more kiddos near us who have ASD.
So I'd say probably the best thing they do is the Regional Autism Assistance Program and going through Family Navigators. And Allison, you can jump in on this if you have other information, but that's usually where I send people. It's not enough. We know it's not enough, but that is usually the best way to say, like, hey, can we get connected with a parent group or with some more information? Again, I believe the Autism Society of Iowa also has some parent groups, some in person and some online. And they also, I think, do have some like social groups for teens and maybe autistic adults as well.
Yeah.
I don't, Allison, do you know of anything else?
Yeah, I mean, our family navigators are statewide, so they are they do a really great job of helping families get connected to some of those resources and just providing general support. So if you have anything specific you're looking for, feel free to reach out and we can get you connected with a family navigator. Do you often find both ADHD and autism together?
Yeah, a lot of the time. I'm trying to remember, I feel, do not quote me on this, but the number 40% of the time sounds right. Um, Again, we need to make sure that what we're seeing isn't just explained by one or the other. Some of those sensory differences can be present in both. Inattention in ADHD versus I'm not socially engaged enough to notice or care about what you're doing can be hard to rule out, but we definitely see a substantial number of folks who have both ADHD and autism.
Do you ever see the regression starter? Sorry. Do you ever see the regression starting later than 3 years of age?
Until oh, a few weeks ago, I would have told you no. Rare to the best of my knowledge, and probably associated with some other medical things going on. If we're seeing regression, especially substantial regression, starting later than that. So autistic folks can have regression throughout the lifespan, but like if we're seeing it start later than that, I'm going to want a really good medical workup before we do anything diagnostically.
What do we do if the state says no, but the doctor says yes regarding a diagnosis?
The state in terms of, are we talking like in terms of SSI or something like that?
That's what I was
Okay.
going to.
So I'm going to go based on that assumption and people can correct me if I'm wrong. So that's a little bit tricky because SSI has its own rules for what qualifies as disabling. So it is absolutely possible for a child to meet the diagnostic criteria for autism or an adult. And for the state to say, no, there isn't enough impairment here for us to feel that they meet criteria for support. I did also learn at my conference last week that I think it's like 60% at least of initial SSI applications are denied. So it's probably worth reapplying, particularly if you are seeing areas that your child is not supported in that you would like additional help with.
Can people change from different autistic levels, or will they pretty much stay the same level throughout their life?
I don't think we have great research on this yet, but what I would say from what I've observed is that the younger you are, the more changeable your level is, the less stable it is. So I have seen, if any of you, if I diagnosed any of your children, you probably know that and they were 2 or 3, you probably know that I was kind of resistant to giving a level, or that I said, well, gave kind of a politician, neither here nor there answer. Um, because I have seen kids who did not have a whole lot of speech at age 3, and then by 5, they're giving lectures on whales. And so at level 3, I might have put them at a level 2 to, or excuse me, at age 3, I might have put them at a level 2 to 3. Um, and then at age 5 it would be a level 1. Um, I think the older you get, particularly once we get into 5, 6, especially if we've had interventions in place already, I think it's less likely that that level is going to change. But that doesn't mean that we can't expect to see improvements or that folks can't learn new skills. That's always on the table. It also doesn't reflect that people have good days and bad days. Autistic people are no different in that than any of the rest of us. So you might have someone who has a level 1 diagnosis who has an absolute meltdown one day. And if you just saw them in the context of that behavior, it looks like they need higher levels of support.
My son is 2 years old and was diagnosed in August of this year.
Mhm.
Is 3-year-old preschool a necessity since my child is doing speech, physical, occupational, and ABA therapy?
I think that is always a family decision. I always tell families you figure out what works for you. If if what is working is going, if if what you've got is working, I'm hesitant to change it, especially at that age. Um, if, maybe you let them sit out 3-year-old preschool and then you try 4-year-old preschool, or you do half day preschool or half day ABA. ABA preschool, speech, occupational, and physical therapy. I'm not going to say no child has ever done it, but that tends to get to be a lot for most kids. And so I I am not stressed if I hear somebody say, "Oh yeah, we ditched 3-year-old preschool because our current therapy services were working well for us."
What is your personal opinion for the increase in prevalence?
Yeah, I think it is a lot of what we've talked about today. I, this is based on the selection of kids who I have had the opportunity to see over the years, but I have seen a decent number of children who had either birth complications or who were born extremely premature, like 22 plus weeks. Um, and a lot of them did have developmental differences. And I don't think we can overestimate the widening the spectrum that we've done. Like I said, when the presenter I heard last week said um, most of this increase in prevalence is in children who have average or higher IQ and language, that to me was like, oh, okay. Because those are the kids who tend to be harder to identify, especially, or who nobody was looking at before. I did not know a single person identified with autism until I was in college, probably. But looking back on my school career, I can think of at least a couple of my peers who I'm like, yeah, I think that was probably a thing. They missed a lot of social cues. They maybe got fixated on some interesting things. Um, and so I do think that's a large part of it. But I think, the other factors like advanced parental age, maternal inflammation, and um, difficulties surrounding birth contribute as well.
Well, thank you everyone for joining us today, and thank you, Dr. Reiher, for all of this great information. I will be sending out the recording links and certificates of attendance later this afternoon. If you don't receive it for some reason, make sure to check your spam folder. Sometimes they like to show up there for some reason. Um, it- but otherwise, we will see you all next week for the session on therapy sessions.